It looks like it's 11:01, so we'll get started. Good morning, everyone, and welcome to today's webinar, Social Prescribing Through a Health Promotion Lens. This webinar is the first of two webinars in Health Promotion Ontario's Fall 2025 webinar series, exploring emerging topics in health promotion. My name is Jillian Herring. I volunteer with Health Promotion Ontario, and I look forward to moderating today's session. I would like to begin by acknowledging that I'm speaking with you from Mississauga, located in the Greater Toronto Area, within the treaty lands and traditional territory of the Mississaugas of the Credit First Nation, the Haudenosaunee, the Huron-Wendat, and the Wyandot Nations. As we have folks joining today from across Ontario, I encourage you to take a moment to reflect on the land you are joining from and the Indigenous peoples who have lived on and cared for the land since time immemorial. This webinar is hosted by Health Promotion Ontario, a volunteer-based organization whose vision is to promote the health of Ontarians through excellence in health promotion practice. We encourage you to consider becoming a member and would also like to note that Health Promotion Ontario is looking for members to join its executive committee. If you are interested in this opportunity, please email healthpromotionontario@gmail.com to learn more and keep an eye out for our soon to be launched new Health Promotion Ontario website. Today, we are excited to dive into the topic of social prescribing and health promotion. And we have three wonderful speakers here to share their unique experiences and insights in this work. And a couple of housekeeping items before we get started. This webinar is being recorded and will be available to all participants after the session today. Today's session will include presentations from three of our wonderful guest speakers and a live question and answer period following their presentations. Please feel free to submit your questions using the Q&A function in Zoom throughout the presentations, and we look forward to looking to those questions during the Q&A period. And finally, if you are experiencing any technical issues that you are unable to resolve during the webinar, please reach out to my colleague Amanda at amongion@uoakguelph.ca, and my colleague will share the email in the chat as well. And with that, I am so excited to introduce our speakers for today's webinar. First, we have Maria Morais, a supervisor of the mental health promotion team within the Chronic Disease and Injury Prevention Division at the Region of Peel Public Health Unit. Maria leads strategic initiatives in mental health promotion and chronic disease prevention grounded in evidence-informed practice, health equity, and multi-sectoral collaboration. Today, Maria will be discussing Peel's experiences with social prescribing and future opportunities for social prescribing in public health. Today, we also have joining us Kobisha Rajaswaran, joining us as a Master of Public Health student at the Dalla Lana School of Public Health. Kobisha completed her Master of Public Health practicum with the Novo Nordisk Network for Healthy Populations. Her recent work during her practicum focused on community asset mapping for social prescribing in Peel Region, and we are so excited to have Kobisha share more about this project during today's webinar. And finally, we are very excited to have Natasha Beaudin joining us. Natasha has spent over 20 years working in the community health sector and is currently a social prescribing lead at the Alliance for Healthier Communities. We look forward to hearing Natasha speak about health equity-focused social prescribing. And without further ado, we'll kick off today's webinar with Maria's presentation.
Welcome and thanks for inviting me. Today we're going to talk about social prescribing in action, experience from the region of Peel, and some public health opportunities. So if social prescribing is new to you, it is an emerging approach in Canada with its roots in the UK as an integrated part of their national healthcare system. and it continues to grow rapidly across Canada, and often thinking about it as a complementary, integrated approach that strengthens and builds capacity for improved ways that we can address health promotion and chronic disease prevention. The learning objectives for this session will be to understand the concept and value of social prescribing as part of health promotion. We'll share how the region appeals exploring social prescribing with some application of social prescribing in health services, as well as the opportunity for social prescribing in health promotion practice with some next steps. Following my presentation, you'll hear from a master's student who conducted a community asset mapping in Peel project for us. What is social prescribing? Well, social prescribing connects people to non-medical resources and services in the community. It uses a strength-based approach in public health, health promotion principles, and thinking about people that have chronic conditions often experience health-related social needs, often due to social determinants of health, including socioeconomic barriers, inadequate environments, limited healthcare access, and perhaps a lack of social support. And these factors can significantly impact chronic disease management, yet we know that a lot of our care models prioritize clinical services, often neglecting or not having the capacity to address social supports. So we are also learning that social prescribing is gaining momentum with initiatives targeting very diverse populations in the community, looking at caregivers, youth, racialized communities and groups, as well as Indigenous communities that can often address initiatives through a health equity lens and social determinants of health. In a time of healthcare costs being unsustainable, it's interesting to see the cost benefit and savings that can be afforded and reinvested as a result of social prescribing. In a recent report called Bridging the Gap Between Health and Social Care from the Canadian Institute for Social Prescribing, we can see that social prescribing has been shown to reduce primary care appointments by 42% and a reduction of 24% of visits to the emergency department. With a focus on health promotion and diversion from primary health care, we are seeing a return on investment of almost $4.50, and this ability to address the social determinants of health within the community, it can save costs in the primary care system. So thinking about how social prescription fits within health promotion, that's one of the reasons why you're all here today, is that rooted in the 1986 Ottawa Charter for Health Promotion, there are several levels of intervention from the individual to the population level, where we can see social prescribing supporting between public health and healthcare services with the quintuple aim for healthcare improvement. The Ottawa Charter for Health has a vital reference for health promotion efforts worldwide, guiding policies and practices aimed at improving health equity and well-being for all individuals and communities. So a little bit about the regional municipality of Peel. We are made up of the city of Mississauga and Brampton and the town of Caledon, with a fast-growing and diverse community. We're at 1.6 million residents. Our mission and vision are clear. We want to see community for life and working with others to achieve a healthy, safe, and connected community. We are the second most populated region in Ontario, including urban, suburban, and rural population, and incredibly diverse, with 69% of residents identifying with a racialized group, compared to 34% in Ontario and 27% in Canada. So with these unique characteristics, it brings us an opportunity and challenge to address widening health and social disparities across different equity-deserving groups in Peel. So as part of the thriving component in our mission statement and vision, we often think about how people can flourish in our communities, and that there are several well-being markers and measures that we can look at, anywhere from overall community well-being to the political well-being, economic, physical, and psychological, as well as the social and cultural. This Peel Community Flourishing Survey was conducted to help the Trillium Health Partners 10-year strategic plan to help foster a holistic approach to health and well-being, as well as establish goals of the broader Peel community to create a new kind of healthcare system for healthier communities that support a healthy, safe, and inclusive community where all citizens can flourish and thrive. And so we think about how social prescribing can be part of that flourishing opportunity. So this year we've started to do some internal sharing and learning and consultations across our health services and looking at approaches being used for social prescribing at Peel. We have consulted with Dr. Kate Mulligan, one of the international experts on social prescribing out of U of T, and for our health services folks in the seniors services development, our paramedics and public health, as well as the community safety and well-being plan that offers access to multiple community organizations. So the one area, senior services development, has certainly stepped out as lead on social prescribing with a pilot for caregivers, and looking at multiple pathways of prescriptions through social workers who connect to caregivers and prescribes nature prescriptions, arts and culture, caregiver retreats, and have offered, in partnership with a local university, a 5-week micro-credential to provide additional education. Some of the outcomes that we've seen is increased well-being and confidence in the caregivers, and a decrease of stress and reliance on healthcare providers. Certainly we've seen lots of partnerships leveraged during this pilot. On our public health, and we have 5 strategic priorities in our plan currently, where we're focusing on enabling active living and healthy eating, promoting mental well-being while we're advancing health equity, and reducing health-related impacts on the climate change, all through use of our public health practice and effective way of working, and looking at the opportunity for a comprehensive health promotion approach using a social prescription as embedding into some of our work. Next, I'll talk about the internal consultations we've had, looking at a gathering to look at opportunities, barriers, facilitators, and what kind of supports are needed to think about when implementing social prescribing at the Region of Peel. So we asked, what are the opportunities for embedding social prescribing in your program area for our internal process of consultation? And participants suggested various things. So within our paramedics, they suggested isolation as an issue that was identified during home visits. So looking at the opportunity to implement social prescription referrals. Within public health, possibilities around schools for youth belonging, a sense of belonging, and our Healthy Babies, Healthy Children. Is there a way to target pilots with new moms And for evaluation purposes, can we track outcomes such as loneliness, well-being, and service usage? For our senior services folks, wanting to expand social prescription to other long-term care facilities, looking at hobby re-engagement and caregiver groups. For family health, can we, during wellness calls, have some referrals? Across sectors, establishing a dedicated social prescription hub and low barrier community settings like libraries, housing, and youth hubs. And in terms of academic partners, partnering with them to support training, evaluation, and curriculum. Some of the barriers and facilitators that we looked at included funding and capacity. So the lack of sustainable funding for social prescribing and dedicated staff, perhaps. There's also a global movement as an opportunity. Well, the Canadian Institute for Social Prescribing. There's some federal level grant funding opportunities that can be leveraged for pilots. At a system level, grant gaps and enablers included possibly fragmentation. Maybe there's too many partners, competing demands, and overlapping services. Our mandate could be one of either overlap or where things don't align. And however, champions can also already exist in some of our areas and learning from them. There's also some process challenges, so referral pathways are maybe unclear and no consistent community resource directory or lack of evaluation frameworks. And finally, addressing what kind of support, resources, and information folks during our internal consultation would need to embed social prescription into their program area included staff training of different members from frontline to management staff for orientation of social prescription concepts. What is it? Why is it important? How it works. So some ongoing training and professional development to equip staff. Secondly, sustaining resources for staff and activity costs so that projects wouldn't be one-off and it would be embedded into the roles of folks. Leadership buy-in is always an important aspect of being able to have cross-departmental collaboration and integration as part of organizational goals and plans. Having a centralized resource directory that folks can have a consistent way to identify and prepare referrals, as well as organizational mandates, building community connections. So to have a successful social prescribing program, to look at what are the community connections and standard expectations in different aspects of our mandate and aligning those with other organizations. Starting to wrap up, we are certainly in a learning curve at Peel and looking at our role in the Ontario Public Health Standards and aligning social prescribing interventions as part of a comprehensive health promotion approach or a population health approach. We can be connectors and bring people together, look at evaluation for some outcome measures and for health equity, and certainly adding to that return on investment. It is an emerging approach, and we are continuing to learn. We're part of communities of practice, and I encourage you to get involved so that we can look at ways to foster cross-sectional collaboration and build connections within the healthcare system and the social care system while we support community well-being that is beyond primary care. I'd like to offer some helpful links that might help you in understanding a little bit more about health promotion and social Prescribing. And with that, I'll leave you with my contact information. Thank you very much and look forward to hearing my colleagues in the next segment.
Thank you so much, Maria, for your amazing presentation, really providing us with a foundational understanding of social prescribing and discussing what public health's role in this work can look like. And we are very excited to continue this conversation about social prescribing at the region of Peel with Kobisha.
Hi everyone, thank you so much for having me. My name is Kobisha Rajaswaran. I use she, her pronouns, and I'm a second year Masters of Public Health student at the Dalai Lama School of Public Health, studying in the Social and Behavioral Health Sciences stream. And so today I will be sharing about my summer practicum research experience and building off of Maria's presentation to talk about leveraging community asset mapping for social prescribing in the Peel region. So this project was a result of my summer practicum supported by the Novo Nordisk Network for Healthy Populations. So this is a research network at the University of Toronto, Mississauga that aims to reduce inequities and risk and burden of chronic disease through co-creation of locally relevant solutions that can really help to improve health outcomes for a specific community. So this practicum was supervised by Dr. Kate Mulligan, who is an associate professor at the Dalai Lama School of Public Health, as well as Dr. Nada Hassan, who is a postdoctoral fellow at the University of Toronto. So this project was focused on conducting community asset mapping for social prescribing in the region of Peel. It aimed to identify and map local community resources in the region to help support future social prescribing as an approach to connect individuals to non-clinical supports to improve their health and well-being. There are really three main objectives of the project. First, to build knowledge of the community assets that can address the social determinants of health of individuals within the region of Peel. We also were interested in exploring the gaps and needs to feasibly implement social prescribing in these communities, as well as identify lessons learned that can be leveraged for future social prescribing in the region of Peel. And this work was conducted in collaboration with the municipality as well. Before I go further into the project, I want to situate a little bit more about what community asset mapping is. So community asset mapping is this process of identifying resources, strengths, and opportunities within a community. And in the context of social prescribing, these often lead to the pathways and prescriptions that are offered to individuals in a social prescribing program. Asset mapping and community asset mapping really goes beyond just listing out organizations. It's a collaborative, strength-based process that really fosters community capacity, sustainability, and equity by highlighting hyper-local, culturally relevant supports that can help to serve directly into the community. Assets can be identified in a number of different ways for community asset mapping, and it really depends on the purpose and the scope of the project that the asset mapping is being conducted for. And so just to name a few, assets can be described as physical and mental health support and be listed through that. There's also social connection and belonging-based assets such as senior programs, youth groups, faith groups. There's also art and culture-based activities and programs that can be described as community assets, as well as nature and the role of nature in terms of public green spaces, community gardens, and other nature-based programs. So these are all just different ways that community assets can be understood. And in this project in particular, we looked at a variety of these community asset categories in order to be leveraged for social prescribing. So the question for why Peel? This project focuses on Peel in particular because of the unique demographics and situation of the Peel region, as well as the ongoing and existent support from the region of Peel municipality as shared by Maria. And so within the region of Peel, there is a large burden of chronic disease, and social determinants of health are really contributing and exacerbating these health disparities, as we know from health promotion principles. So diverse social determinants of health in the population, including high population of racialized individuals, newcomers and immigrants, as well as low-income communities, describes Peel as a key spot where we can use social prescribing to leverage and improve the health of all of the community members. However, the same way with social prescribing, in where we don't want to take a deficit-based model, there's some really key strengths in the region of Peel that also make it a great place to conduct this community asset mapping to leverage for future social prescribing. We know that there are extreme strengths in the region with a wealth of community knowledge, social organizations, innovative public health units, and health system leaders who are doing great work, as well as a really great culture of community participation and engagement. And so using this background knowledge and leveraging these assets and strengths already existent in the community, this project aimed to develop these asset mapping products and build community partnership to help inform the future co-design of social prescribing within the region. So there were several phases of the project that I was a part of. We first started off by conducting an environmental scan of existing community resources and assets that we can find as a whole. So these assets were categorized by any program, service, space, or specific person and strength that is facilitating well-being in some way. We then had these community assets from the environmental scan invited to participate in our asset mapping workshops. With the help and the co-host of the Region of Peel, Maria's team, and individuals at the Region of Peel, we invited a number of different community organizations, individuals with lived experience, health system, and public health leaders as well to participate in an engaged discussion to help map community resources and assets, as well as to conduct discussions around the future of social prescribing in the region. Finally, taking all of this, I was able to produce some knowledge mobilization resources, including findings from the workshops, as well as a functional map that was created with the community assets that I will show as well moving forward. So first, to talk about the community workshops. So as part of this project, we conducted 2 community asset mapping workshops, one in person at the Region of Peel Mississauga office, as well as one online. So co-hosted with the Region of Peel, these sessions invited a number of different health and social service organizations, community members with lived experience, and individuals in the public health community to collaboratively identify community assets within the Region of Peel. Additionally, the workshops also helped to explore shared priorities and discussions for the future direction of community-based social prescribing, and I'll share those findings as well down below. But here are just a few of the different organizations that were represented at the community asset mapping workshop. It's also important to understand that this is just the beginning. It is not a comprehensive list of everyone who could be there and who is considered a community asset, but really just a stepping stone of connecting and engaging with the community for social prescribing for the future. So in terms of the workshop, we were able to generate discussion for participants, firstly around the facilitators and barriers for community assets within social prescribing. And so firstly, one of the major strengths that was recognized within the community is the cultural, faith, and ethnic networks, specifically culturally tailored program and strong newcomer settlement services that were described as trusted, holistic, and culturally relevant pathways that can be leveraged for social prescribing. Additionally, informal networks and community spaces such as peer-to-peer support, public gathering spaces were recognized as being really essential and sometimes overlooked hubs that can help to foster communication, resource sharing, and access to support beyond the formal systems available. Another really key asset that was another really key strength that was described in the assets is the strong culture of inclusion and community leadership. There are a number of different local champions, informal leaders, and grassroots initiatives as well that are really helping to mobilize engagement, foster belonging, and provide momentum to really formalize and scale social prescribing as a whole. In addition to these assets, there were also some barriers that were described to limit the development of formal social prescribing pathways in the region. So these challenges really reflect both structural and systemic issues in the terms of how community assets are resourced, accessed, and coordinated. So historically speaking, short-term and competitive funding were seen as creating strain on organizational capacity, further limiting the sustainability and scaling of social prescribing efforts. Similarly, barriers to collaboration, such as system fragmentation, also were found and expressed as being limiting to the equitable access and visibility of community assets within a social prescribing pathway. However, from these asset strengths and barriers that were described, we were also able to generate key lessons that help to capture the future of social prescribing in the region. So firstly, across the board, participants unanimously envisioned a social prescribing model that is really centered around service integration and serving the community. In line with these health promotion principles as well, there is this really key emphasis on inclusive and community-driven services that help to bring efforts and awareness to social determinants of health, culturally relevant wraparound supports, and increasing the use of public spaces to really meet communities where they are. To ensure the efforts towards follow-up and feedback for social prescribing are implemented, there are also actionable recommendations that were identified to ensure that evaluation and tracking of future social prescribing initiatives was essential and possible as well. All of these identified community assets that were built and listed and described during the community workshops and the environmental scan as a whole were also incorporated into this functional interactive map that you see with the snapshot pictured here, and really describes one of the key products that was able to come from this research project as a whole in creating this functional map that really organizes, categorizes, and houses the key community assets that can be leveraged and continue to iteratively be added to for social prescribing as a whole. One of the key takeaways that I see from this work is understanding that community asset mapping is a really key initial step to building strong community-based social prescribing. As part of this work and informed by the community asset mapping in Peel, I was able to understand that one of the main outcomes of community asset mapping as a whole is also really the relationships and engagement that is built through the process. This engagement is really helpful and key for ongoing collaboration within future social prescribing as a whole, and I look forward to seeing that within the region of Peel as well. This work that I was a part of was also able to help inform a comprehensive national guide that is being built in partnership with the Canadian Institute for Social Prescribing, co-developed with national implementation leads from all of the social prescribing provinces in Canada. And this will be available next month as well on the Canadian Institute for Social Prescribing page for individuals who are interested to contextualize community asset mapping in their own communities as well. Thank you all so much for listening to this presentation. I really look forward to seeing this work continue at the Region of Peel and also to connect with all of you for any questions or further discussions to be had.
Thank you so much, Kobisha, for your engaging presentation today, sharing more about such an important community asset mapping project in Peel Region. And now we will turn it over to Natasha.
Hi there, bonjour. My name is Natasha Beaudin, and I'm the lead for social prescribing at the Alliance for Healthier Communities. I've been with the Alliance for more than 3 years. Prior to that, I worked as a health promoter at an urban CHC in Ottawa for many years. The Alliance is a network of over 120 community-governed, comprehensive primary healthcare organizations across Ontario. That includes community health centers, nurse practitioner-led clinics, Indigenous primary healthcare organizations, and community family health teams. These organizations share a commitment to advancing health equity through the delivery of comprehensive primary healthcare. They serve populations systemically marginalized and underserved by other parts of the health system, those who face the greatest barriers to health and the poorest health outcomes. These organizations are team-based and typically deliver a range of clinical, allied health, health promotion, and social and community support services. Just to review a couple of foundational documents that help guide our thinking at the Alliance. So first of all, the Health Equity Charter. The Charter is a living document oriented to advancing health equity through a human rights and social justice approach and driving change at all levels, system, policies, as well as organizational and individual practices. The second set of foundational documents are the Model of Health and Well-Being and the Model of Holistic Health and Well-Being. The Model of Health and Well-Being is a evidence-informed model to guide the delivery of primary health care. The model defines health in the same way as the World Health Organization, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It incorporates a health promotion, health prevention lens, and includes addressing the social and structural determinants of health. It includes equity and community governance. For our Indigenous governed organizations who operate from a holistic Indigenous health framework, this model of holistic health and well-being is what grounds their work. Oops. So just a quick note on equity and equality. So they're not the same. And equity is making sure that everyone has the opportunity to attain their full potential. So not treating people the same, but by providing the right level of ladder to ensure that people have what they need to achieve full health. And we know that just changing the ladder isn't enough. We need to remove the barriers altogether so that we can achieve justice. I'm going to go over a little bit of our social prescribing work here at the Alliance. So it all started in 2018 with the social prescribing pilot, where we worked with some mentors from the UK to design a social prescribing way of working that is unique to Ontario. So we worked with 11 different CHCs across Ontario and a mix of urban, rural, francophone, and northern communities. And that's where we really proved that it could work in this setting. Next came Links to Wellbeing in 2021, which is social prescribing for older adults. It's a partnership with the Older Adult Centres Association of Ontario, and we're trying to make a seamless referral from healthcare to community, in particular to the Seniors Active Living Centres and other community organizations. So we have about 100 seniors centers, about 200 healthcare providers, and 30 of our member centers involved in this project. Next came the Social Prescribing for Better Mental Health. That was an 18-month project funded by the Public Health Agency of Canada, and we were able to work with 28 sites across Ontario to help them build and improve their social prescribing pathways. So looking at ways to make social prescribing really sustainable. And part of that was quality improvement coaching, developing resources and tools to better support social prescribing. And out of that came our online learning modules. I'll talk a bit more about that later. And then Black Focus Social Prescribing, a 2.5-year pilot project to develop a model of social prescribing that improves healthcare experiences and healthcare outcomes for Black Ontarians and Black communities. So we're currently working with 4 sites and hoping to spread and scale this work. So I'll take a little bit of a deeper dive into that project in particular. So as I said, a 2.5-year pilot aims to augment social prescribing practices by developing a culturally affirming model of care specifically designed to address the unique health inequities faced by the African, Caribbean, and Black communities. So we had over 4,000 clients participate, and out of these clients, about 1,600 received social prescriptions. So it was implemented by the Alliance, but delivered by 4 CHCs. So Black Creek, Somerset West, Tyboo, and Rexdale. And we have these dedicated staff called link navigators that help connect clients to programs and services. So these navigators work with both clinical and non-clinical providers to help clients access the care and resources they need. I think the greatest skill that our navigators have is that they know the community and are very thoughtful about each prescription, making sure that it will always be a culturally affirming experience for the client. And then we also have the managers and directors at the CHCs to ensure it runs smoothly, while the Alliance provided overall project management and support. And to ensure that this project was Afrocentric, it was guided by the 7 principles of Kwanzaa. And so there was a lot of reflection and always coming back to these principles and making sure that we were working within these values. In particular, the Nia, Kujichakulia, and Ujima were the 3 guiding principles that guided this work the most. And just a little quick word about the evaluations. So we worked with logical outcomes, which provided a developmental evaluation approach focused on continuous learning and adapting to changes in program needs, while Transform Practice conducted a participatory evaluation. So participatory evaluation facilitates collaboration by involving community members as co-leaders and knowledge experts, as experts on their own experience. And the Alliance itself also contributed to the evaluation by synthesizing outcomes from client data reported by participating CHCs in the electronic medical record. And just to share some of the results from our evaluations, so 89% of participants reported feeling a stronger sense of belonging with their community after participating in Black focused social prescribing. 90% of participants reported that their trust in service providers had increased. 87% felt their health and well-being had improved. 40% participated in culturally affirming wellness activities, and 30% engaged in mental health services. And so just to share with the participatory evaluation, it wasn't focus groups, it was more like data parties, we called them. So there was food, there was art, it was very accessible, and there was a very festive atmosphere. And that's where we heard some of the stories about, at first glance, you might not think, oh, a hair drop-in, what does that have to do with health? But when you hear the stories from the clients, one client in particular had not been leaving her home. She was about to graduate from a program, but she wasn't planning to go to the graduation ceremony because she didn't have the means to get her hair cut or to get her hair done. And that just had such an impact on her confidence and her self-esteem that she actually wasn't leaving her room. She heard about the hair drop-in, and she went to the hair drop-in and she said, like, imagine my surprise. I didn't have to explain about Black hair. Not only did I not have to explain about Black hair, but this person knew my home country, they knew my culture, they knew my language. And for the first time since coming to Canada, I felt I was at home. Going to this hair drop-in led to some food security programming. So that was the next on the list, was kind of, a lack of food in the home. And then slowly but surely, this person was able to connect to healthcare services, and they hadn't received healthcare since they had come to Canada. So many ways, sometimes the social prescribing referral comes from healthcare to the community, and sometimes it's meeting with someone you trust and building a trusting relationship with the healthcare system that can help you access those primary healthcare services that are really needed. Just going to share one of the tools we used with the participatory research. This is an outcome star. So these were some of the goals that we were trying to accomplish with the project, and clients could put a sticker to show, did this project help decrease your sense of loneliness? Did it increase your knowledge, your self-efficacy, your ability to navigate programs and services? So just showing one of the interesting and different accessible kind of evaluation tools we used. So some images from Black Creek. So just sharing, this was a health fair held in a mall. There was food, there was music, it was fun, it was lively. And while you're there, you might, oh yeah, there was an beautiful quilt was unveiled. And while you're there, you can also get your blood pressure checked, find out more about health programs. So again, making healthcare fun and accessible and meeting people where they're at in the community. And so, if you would like to know more about social prescribing, if you want to get more involved, this is an amazing tool. We worked on with the Center for Effective Practice and the Canadian Institute for Social Prescribing, a tool for health professionals to implement social prescribing in their practice. So, feel free to scan that QR code. I have 5 project videos that show social prescribing and um, how it can be implemented in different settings. So we have beautiful Linda in Cornwall at Seaway Valley CHC in the community garden, and then some folks from Regent Park at the AGO doing some art programs. And we also have examples from what it might look like in a nurse practitioner-led clinic or a francophone center. So feel free to check out those videos. I also would like to share, we have this 1 minute video that is like an ad for our free health equity focused social prescribing online learning module. So just encourage you to check that out on YouTube and feel free to share it because at this time, the modules are all still free. So just wanted to share that with you all. Other ways to get involved. We have an Ontario social prescribing community of practice that meets every second month, open to anyone in Ontario who has an interest in social prescribing. There's also a Canadian social prescribing community of practice run by the Canadian Institute for Social Prescribing. I've already mentioned we have our online learning modules, and this came out of our Social Prescribing for Better Mental Health project. We asked people implementing, what would you have liked to have learned? What would have worked for you? So we have these 10 modules. One is specific for clinicians, and it's 30 minutes or less, a very short clinician-focused module. The other 9 modules are more general, getting your interdisciplinary team together, how to start your project, how to work with clients, how to work with volunteer programs, how to use your EMR, all of these pieces that we heard from people implementing that they would have benefited from learning about. So feel free to check that out. And we also have at the Alliance for Healthier Communities a health promotion community of practice. So that also meets every second month, and you can feel free to reach out to our manager of research, Sarah Botti, to become involved with that. And we also have my slides are a little slow here. So, okay, we also have some final reports public. I'm happy to share them. Our links to well-being phase 1, final report, social prescribing for better mental health. Link workers work is a document that really makes the case for why every health setting needs a link worker. And the final report from our Black Focus Social Prescribing project. So please feel free to go and check out those final reports. And a call to action. So if you're all fired up and you want to know how you can help support some change around this area, so we're asking that we ensure that social prescribing and link workers are included in plans to create primary care attachment for people in Ontario. Provide all interested health providers with access to link workers and health promoters to support their clients, and advocate for neighborhood health homes. This is a model that provides barrier-free access to an interprofessional team, health promotion, and community supports. So those would be my calls to action for you today. And thank you. That brings me to the end of my presentation, and I look forward to following up and answering any questions you might have. Thank you very much.
Thank you so much, Natasha, for discussing all of the health equity focused social prescribing projects that you've supported and the positive, long lasting impacts that they've had for community health and well being across the province. And we'll now move into the Q&A portion of this webinar. And I see we have all of our guest speakers on screen with us today. I do encourage our attendees to share any questions that they have for our speakers using the Q&A function in the chat. And I don't see any right now, but I'll give everyone a moment to add their questions. And maybe I can start us off um, by asking, and I'll open this up to all three of you. One of the key takeaways for me across all of your presentations today and all of your social prescribing work is really the importance of that community focus in social prescribing and having community at the center, including collaborating with community organizations and supporting local champions. As we see that social prescribing is gaining momentum locally and across the province, how can we ensure that community stays at the center of this work?
Maybe I can jump in. So we had a really good presentation, I think, from Natasha, who is on the ground and seeing all of these initiatives really impact some of the connections between community and individuals that may be new to the country or trying to find their space and their culture and connect. And I think that that example with the data parties and connection to hair, that's a really important connection to culture and individuality, and by having met that need is really important. So at a broader community level, for the Region Appeal, it's knowing the ever-changing lens of our community, who's in our community, how it evolves, who's coming in, who's most affected with the chronic diseases that we're trying to keep on track. With the region being so large, of almost 1.6 million, it is virtually impossible without all of our health and social services that have an ear to the ground and who are the face of our community. And having services that can meet the individual and collective needs is important, and that's why we all need to work together and have that sort of leadership and cooperation across the systems and start to really look. We talk about integration. There are lots of challenges in doing that, but my hope is that we can continue to collaborate and integrate where we can
Mm,
and share that power and share our resources. We know that there's not a lot of new funding coming, so it's how we work together to utilize what we have.
And
Thanks so much, Maria.
maybe I'll just add a little something. So when I think about the link workers working with the client, it's often like instead of asking what's the matter with you, it's asking what matters to you. So sometimes,
Mm,
when that was part of my role, it was like I might get a referral and the physician or the clinician might have had sort of an idea of what might support that client. And then you sit down and you talk to the client and you ask them, what you help them identify what their goal is and help them work towards
mhm,
something. And it might be something different than what the clinical staff think. It might be, their
mhm,
passion, their interest. If you can kind of support them working towards their goals, that's how you keep it community focused as well, because
mhm,
there's lots of interesting strengths and journeys that I've seen clients go on. And it's very hard to predict what getting someone out of their house, getting them to a social connection group, and then they start to make some social connections. And then they're like, I might just do that exercise program my doctor's been nagging me about. And then, you know what, I might do the training to become a leader of the exercise group. Like it's amazing watching people go on that journey. And it takes a lot of like that trust building is so key, but also that active listening to really hear what people need and supporting them and making sure it's culturally affirming and
mhm,
connections to community.
Yeah, and I just want to add, echoing both Maria and Natasha, I think there's really something key about that cross collaboration. There might be one organization that has the space for, the social prescribing. There might be another organization or another group that has the population who is looking for that social prescribing. There might be different communities that come together and organizations that come together to bring those services. So even the cross collaboration in terms of how that social prescribing is implemented allows for all of the different organizations and disciplines as well in terms of institutions, regional municipalities, community health centers to really all come together for a social prescribing program as a whole.
That's great. Thank you all so much for your insights on that question. I really like the framing as well around what matters to you and asking the clients and community organizations as well as what really matters to the community and the population. And how can we have that cross collaboration and integration to best support the community with regards to social prescribing? Just looking in our chat here, I see a question for Natasha. In your experience with the pilot involving the Black Focus social prescribing pilot, what challenges stood out to you or required particular attention in that work?
Hmm. Um, I think that the challenge was making sure we did it right. And so, like, naturally, I'm a bit of a project manager. I want to reach some deadlines. I want to try to move things along. And we had to go slow with this project. And really, it was the steering committee that led the work, and I supported the steering committee. So being really thoughtful and making sure we were doing it right. And I feel like the navigators were the steering committee, the navigators and their managers, and they were really thoughtful about making sure we were doing it right, thoughtful about every single social prescribing referral, thoughtful about the programs. We had a really in-depth consultation when we were designing the evaluation, and then we found that it still wasn't as Afrocentric as we wanted it to be. It was still, we worked with Black-led organizations to do the evaluation. All of the work throughout this project was Black-led, community-led, and Black-led, and we had to stop, put the evaluation on hold, and redo our consultation, rebuild our
Mm.
logic model, make sure that everyone could support the way the work was going. So I think that was the biggest, well, it wasn't, I'm not sure if it was a challenge, but we went slow and did it
Mm-hmm.
right instead of doing something quick and not as good, if that makes sense.
Mm-hmm. Mm-hmm. I appreciate the emphasis on the thoughtfulness and really thinking through the process and maybe having to pause and take a moment and consider work with community and then continue to move that work forward. So thank you for sharing your insights on that. And I think we have time for one more question. We are coming up to 12 p.m. Um, Let's see here. Is there any conversation yet on establishing link work as a regulated health profession, or would this fall under a social worker's portfolio? And I think this might be more tailored to Natasha, but Kobisha and Maria, if you'd like to share as well, I'll open it up to everyone.
I'll start and then Maria can jump in. So there's lots of talk about making it a regulated profession, but even health promoters are not a regulated profession in that way. Um, so I think it's something that's happening right now. There's lots of conversations. So if you want to be a part of that, there's definitely opportunities. And like what I see for link workers, the strongest skill is just like knowing their community members, knowing where the assets are, like using that amazing asset mapping that Kobisha shared, and being able to build trust with your community. I think those are the key skills. And it could be a
Mm-hmm.
social work background, it could be a health promotion background, it could be just being a community volunteer, a longtime volunteer with that experience and knowledge. But I'll pass it over to Maria if you have added thoughts.
Yeah, thanks, Natasha. Yeah, those are great points. I think in terms of regulated, I think there are already regulated professions that are already practicing in this way. We're calling, social prescribing maybe newer language, but we think about some of the work that as all of us as health professionals, regulated or not, we have in our portfolios that we are to know the community. We are to know what can we connect our clients or our populations to have a cohesive community functioning group. Um, and I think about the our community development workers that, at the Region Appeal, we used to have several back in the day where we were embedded right in community and lived with the community set on a day to day and looked at the strengths of our community. So there are many opportunities I think that exist, and not to think of like social prescribing as a totally new, different thing. Yeah,
Mm-hmm.
we've been doing it for many, many years, right? It's
Mm-hmm.
being with community and knowing community and being able to link
Mm-hmm.
people. So
Mm-hmm.
whether that is a community worker, a youth worker, all those formal and informal titles that we often have.
Mm-hmm.
Yeah, I just want to also emphasize, I think, the idea that Maria said that people have already been doing this work, and so there's community champions, your informal leaders. There might be your faith leader who's doing this work for you informally. There may be people in your community who you go to for this type of service referrals or navigation, and so there's also this emphasis, I think, in understanding the link worker role to not over professionalize it and understand that there's space for all of these individuals, both regulated and those individuals stepping out to a link worker role who may not be from a regulated or a professional background. And there's merit in having all of these opportunities and all of these individuals from different walks of life be a part of that link worker role as well.
Mm-hmm. Thanks so much, everyone, and appreciate as well, really just emphasizing that social prescribing is health promotion, and this work is not necessarily new. A lot of us have been doing this work for quite some time, and there's opportunities for so much involvement in the work currently and moving the work forward. And I see we are at time. I appreciate you all for staying a couple extra minutes. And just wanted to say from behalf of Health Promotion Ontario, huge thanks to our three guest speakers, Maria, Kobisha, and Natasha, who shared their time and expertise with us today. And thank you as well to Northeastern Public Health for providing their logistical support. And finally, to all of our attendees for your participation and engagement in today's webinar. Just a quick reminder that the second webinar in our series, A Fireside Chat with Health Promoters, will be held virtually on November 12th from 1 to 2 p.m. EST, and we look forward to seeing you all at this event. And if you haven't already, please encourage your friends and colleagues to register for this upcoming webinar, and my colleague will be sharing the registration link again in the chat. And finally, we'd really like to hear from all of you. Your feedback is really important for us for future webinar planning. So we ask if you're able to take a couple moments to complete the post-webinar evaluation survey using the QR code on the screen. I believe a link will be shared in the chat as well. And following the webinar, that would be greatly appreciated. And thank you so much, everyone. Really appreciate your time and hope you have a wonderful afternoon.
Thank you so much for hosting us.